Mr. Chairman, thank you very much for the invitation. Ladies and gentlemen, it is a pleasure to be invited here to tell you something about the organization of the Dutch trauma surgery model. So this is the patient category we are talking about. For example, a 35-year-old female, fall or jump, pre-hospital intubation, pneumothorax, hypertensive, traumatic brain injury, deglovement, pelvic injury, etc. And these kinds of patients, there's a lot of decision making. And the key decisions to be made, I only show a selection here. For example, what kind of diagnostics are we going to do? Where are we going to do bleeding control, in the OR or the ICU or the angio suite? Which blood products do we need? Do we need a craniotomy? Do we go for early total care or damage control surgery? What type of stabilization, etc. So there's a lot of key decisions to be made for this kind of patients. So who is going to make these decisions? Well, it's going to be the trauma surgeon. Because as a trauma surgeon in the Netherlands, we have several surgical and non-surgical tasks, and our core organizational non-surgical tasks include that we are the case manager for the trauma patient, especially the polytraumatized patient. So we are responsible for the complete initial assessment and resuscitation in the trauma room. We are the logistic motor, because it always takes more time than we want to make transfers, to make decisions, to go to another place in the hospital. So there's someone needed who keep watching at the clock and taking care of the time. So we are the director of the chain of care of the patients, and we bear end responsibility for this kind of patients. We are also multidisciplinary teachers and researchers for optimal care during the course of treatment. So I will show you a little bit about the organization of trauma care in the Netherlands. How are we trained to do all this? How is trauma care organized in non-trauma centers? And what are the operative skills of Dutch trauma surgeons? So the Netherlands has about 16 million people, and we've got 11 trauma centers for roughly 3,000 polytraumatized patients a year. So that's a little bit too much, but just political reason that there are 11 centers. Next to that, there are about 80 level 2 or level 3 centers, and we've got 4 helicopter emergency medical services that cover most of the country. So the level 1 trauma centers, where I work, have 2 important tasks. The first one is patient care, a high quality of care, especially for the severely injured patients, and therefore it is required that those centers have a 24-hour availability of several infrastructural and specialties in the hospital. But next to that, maybe even more important, that we have to make sure that there's a regional trauma care network with all the surrounding hospitals, that we conduct a trauma registry for quality control and performance improvement. We are the tertiary referral center. We do research and education, etc. And we coordinate the disaster preparation in the hospital and outside the hospital. And because this model worked so well in the Netherlands, what we see now is that the trauma centers have been asked to coordinate other types of acute care as well. For example, the cerebrovascular accident patients have a sort of organizational model of regional care like the trauma centers have as well. So the trauma care network has several levels of hospitals, level 1 to 3. They have different specialties and facilities in the hospital, and the pre-hospital triage system is very important in that it helps deciding the ambulance personnel based on injury mechanism, physiological parameters such as the revised trauma score or the injuries that are suspected, whether the patient goes to a level 1, level 2 or level 3 hospital. And this is our trauma care network with several hospitals around Amsterdam, and they're all closer than 70 kilometers from Amsterdam. So the trauma care is really a chain of care, and we have sort of a key role in making sure that the chain works well from the dispatch center until the patient is released from the hospital, and afterwards as well in the outpatient clinic. So what do we have as a training program for that? We've got 2 years, 6 years in total, and our residents are trained in the CanMed competencies. And that is usually followed by a 1 or 2 year fellowship in either of the subspecialties of surgery, like you see here. We have an individual board certification of the surgeons, and the hospitals have several quality and volume measures. For example, more than 40 abdominal aneurysm operations, etc. a year, and several oncology volume measures. So the surgical resident in the Netherlands is trained in these 5 trauma surgical themes, and that includes extremity injury treatment as well. That is an important part of our surgical workload, polytrauma care, burns, etc. And they all have typical clinical situations and key operations that are checked and taught to the residents. So in the level 1 trauma centers, the focus of trauma surgery is really on the polytrauma patient. But next to that, of course, and there's a special funding that only the level 1 trauma centers receive. So only patients, polytrauma patients in the level 1 centers get extra funding from the government. And of course, we deal with a lot of monotrauma or complex monotrauma patients as well. We do the trauma room management, secondary, tertiary care, etc., as I showed you before. But the situation is different in the level 2 and 3 hospitals. There, the workload for the trauma surgeon is much more for the monotrauma patient. And of course, they don't only do hip fracture patients, but wrist fractures, ankle fractures. A lot of musculoskeletal injuries, soft tissue injuries are treated by the trauma surgeons. And next to that, they do general surgery as well. They have more non-surgical or non-trauma staff duties than we have in the trauma center. The thing is that in the trauma patient, especially the multiply injured, there are so many specialties involved, either operative or non-operative, that there's a risk of non-coordination of the whole process of care. So a tunnel vision or a lack of oversight, especially in the first phase when the patient comes in the hospital, is dangerous, and that can lead to substandard care, preventable death and morbidity. And it's all very nicely shown in the study from Karim Brohi. And that's an important quote. The major trauma center is a specialty hospital, not a specialty hospital of specialties. So this is the Dutch Medical Association treatment. It says it's a checklist with 13 responsibilities, and I will only share the first one with you. For the patient, it is clear at all times who is approachable for questions from the family and our family, who is end responsible, is it for the medical treatment, and who is the coordinator of care. And it is important that these 3 tasks are chattered as little as possible. And preferably, they should be in one person's hand. Well, that is exactly what we have done with the trauma surgery in the Netherlands. So what makes us unique in comparison to other surgical specialties? We have a broad training, and that makes us the ideal and logical case manager for the trauma patient. We are about the only specialty involved in the trauma patient that can really perform life-saving trauma surgery. And we have a holistic view instead of a shattered tunnel visions that some other specialties sometimes have. We have an extensive training program and continued medical education that makes us competent, and we are the organizer of care and liaison for those specialties involved. So what do we operate? What type of operations do we do? We do a lot of primary fracture care, treatment of fractures, dislocations, nailing, plating, X-fix, etc. We do the complete treatment, malunion, non-union, etc. Then, if necessary, the truncal trauma, laparotomy, and thoracotomy. We are responsible in a hospital for the soft tissue injuries and soft tissue infections, such as necrotizing fasciitis as well. We have taken out general surgery, acute and elective, from our surgical procedures. But in the level 2 and 3 hospitals, the trauma surgeon has a little bit different work, because there they still do general surgery, either electively or acute. And laparotomies and thoracotomies are rather infrequent in level 2 and 3 trauma centers. We have looked at this in a study published in the Journal of Trauma. In a 3-year period, you can see what kind of procedures. At the time, we were with 3 attendings and 1 fellow. And in that 3-year period, about 60 to 1,000 surgical procedures were done by the trauma surgeons. So it keeps us busy with a mix of procedures. When we look at the disutility, about 60% of all the trauma surgical procedures start during office hours, and the rest during evening or night shifts. But we do have a few issues to be solved. We have to improve the trauma surgical research. The disutility is considerable, and of course there is a sort of overlap with the orthopedical colleagues and the plastic surgical colleagues, and all claim some sort of competency in special areas of or injuries. We need adequate manpower planning for the elderly patients that are coming to us with injuries. So, to finish, is the Dutch model a viable model? I think in the level 1 trauma center, definitely it is, because it's a unique combination of tasks and competencies as compared to other specialties. We deliver high quality of care, research and education, and the vision of the Dutch Trauma Association is that the holistic view is good for the trauma patient. Does it work in the level 2 and 3 hospitals in the near future as well? Yes. If the quality and competency by the trauma surgeons that do trauma surgery and a little bit of general surgery as well can remain guaranteed, and if they find a good way to cooperate with the orthopedic surgeons and plastic surgeons. And they have to carry out their role as case manager of the trauma patient, also the monotrauma patient with osteoporosis or post-traumatic stress disorder, etc. They have to carry out that role well and not focus only on the musculoskeletal injuries. And we need support from the Dutch Surgical Association and the Dutch Trauma Association. So the Dutch model, one of its strengths are, I think, it's a true holistic approach, and we have a wide and attractive spectrum of surgical procedures, and we can deliver a high quality of care. A weakness could be the overlap with the other surgical specialties and the level of disutility. And of course, there are several opportunities in the research collaborations, which will be discussed in this session as well. Sometimes we have to educate the public more about what a trauma surgeon does and where you should go when you have a specific injury. And I think there's place for multidisciplinary teams. For example, we have a spine team in our hospital with a trauma surgeon, orthopedic surgeon, neurosurgeon, and we treat all those patients with spinal column injuries together with the three. We operate together, etc. And that works well. A threat might be that this system is not commonly practiced in Western Europe, and there might come extended certification regulations. Mr. Chairman, in summary, I think the trauma patient needs a case manager, and the trauma center is more than just a set of subspecialties and specialties, super specialists, with trauma expertise only in one organ or one part of the body. The Dutch trauma surgeon is well equipped with skills for optimal treatment of trauma patients, especially the polytraumatized patient, and this brings us an attractive mix of operative and non-operative care. Thank you very much for your attention.